This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled Endoscopic Transnasal Approach to Pterygopalatine Fossae and Infratemporal Fossae, Case Series Utilizing Endoscopic Modified Medial Maxillectomy, EMMM, and the Direct Approach to the Anterior and Lateral Part of the Maxillary Sinus, DALMA.
This is a paper coming out of the University of Tokyo Hospital, led by Dr. Motoyuki Umekawa and colleagues. It addresses a perennial headache for skull-based surgeons, the lateral reach. We've become very comfortable with midline and paramidline lesions using endoscopic transnasal surgery, or ETS. But the moment a pathology moves into the pterygopalatine fossa, the PPF, or the infratemporal fossa, the ITF, the maneuverability drops significantly.
Exactly. In the past, if you wanted to get into the ITF or PPF, you were often looking at highly invasive craniofacial approaches. We're talking about extensive craniotomies or even maxillary mobilization. For a benign lesion, like a schwannoma or a meningioma, that's a lot of collateral damage just for access.
Which is why this study is so relevant. They looked at 5 patients between 2021 and 2024. They utilized 2 specific techniques to open up the corridor, EMMM and DALMA. Alara, let's start with the EMMM. Most of our listeners in rhinology might be familiar with it, but what's the neurosurgical utility here?
EMMM stands for Endoscopic Modified Medial Maxillectomy. The key here is modified. Traditionally, a medial maxillectomy might involve sacrificing the nasolacrimal duct. But in EMMM, they preserve the nasolacrimal duct and the inferior turbinate. They open the medial maxillary wall to get direct access to the PPF and ITF from an anteromedial aspect.
It's about creating a wider window through the maxillary sinus. But as we know, even with a medial maxillectomy, you can still get instrument crowding when you try to reach the far lateral corners of the ITF. That's where the DALMA comes in. This was a relatively new addition for their team, right?
Right. DALMA, the direct approach to the anterior and lateral part of the maxillary sinus. In this technique, the surgeon performs a submucosal dissection that extends laterally beyond the piriform aperture. They actually remove the anterior maxillary wall to create an additional port.
And that's the aha moment of the paper, the dual portal configuration. Instead of trying to shove the endoscope and all your instruments through the same narrow nasal corridor, you separate them.
Exactly. They describe it as a multi-portal access. For example, if you are operating on the right side, the dominant right-hand instrument, say a high-speed drill or a bendable long shaft bipolar, goes through the EMMM corridor. Meanwhile, the endoscope and the non-dominant instrument, like the suction, are introduced through the DALMA corridor.
It's a game changer for maneuverability. By separating the endoscope from the working instruments, you minimize that sword-fighting effect we all hate in deep endoscopic work. They even used a robotic holding arm to stabilize the endoscope, which further frees up the hands.
The paper notes that this arrangement allowed them to expose the lateral skull base all the way to the medial border of the mandible. That is a significant lateral reach for a transnasal approach.
Let's talk about the patients. They had 5 cases. 2 of them had EMMM alone, and 3 had the combined EMMM and DALMA. The pathologies were interesting: a trigeminal schwannoma, an idiopathic CSF leak, and 3 meningiomas that were extending into the ITF and PPF.
And the results were impressive. They achieved gross total or subtotal resection in all cases. In the meningioma cases specifically, where you often have tough vascularized tissue that requires bimanual manipulation, the dual portal configuration seemed to be the key to their success.
I was looking at their technical notes regarding the DALMA. They mentioned the risk to the anterior superior alveolar nerve. Since they are working around the piriform aperture and the anterior maxillary wall, that's a real anatomical concern.
It is. In fact, they reported that one patient experienced slight numbness in the upper lip postoperatively, which they attributed to an injury of that specific nerve during the DALMA approach. Another patient had some slight worsening of facial numbness, but overall the complications were minimal, especially compared to the morbidity of a traditional open transfacial or transcranial transfacial approach.
It's a trade-off. A little bit of numbness in the upper lip versus a full-blown Weber-Ferguson incision or a zygomatic osteotomy. For most patients, that's an easy choice.
Another point the authors emphasize is the surgical trajectory. For lesions in the ITF, you're often dealing with the internal carotid artery, the clevis, and the sella. They combined the uninostril EMMM DALMA with a traditional binostril approach when they needed to access those deeper midline structures. It shows that these techniques aren't meant to replace our current ETS standards, but to expand them.
I think the bendable long shaft bipolar forceps they mentioned are a crucial piece of the kit here too. When you're working in the infratemporal fossa, you're in a very vascular space. You have the internal maxillary artery and its branches. Having instruments specifically designed for that lateral reach is vital.
They also mentioned using a high-speed drill and an ultrasonic aspirator through that EMMM corridor. It really seems like the DALMA port acts as a dedicated viewing and suctioning port, which keeps the endoscope lens clean because it's away from the drill splash zone, and gives the dominant hand a straight shot at the pathology.
The authors conclude that this dual portal configuration, quote, appears to improve instrument maneuverability and facilitate more extensive resection. It essentially expands the applicability of ETS. We're no longer stuck in the midline.
It's a small series, only 5 patients, but it's a proof of concept. The direct approach through the anterior wall, DALMA, plus the medial approach through the nasal wall, EMMM, gives you a wide-angled triangulation on the PPF and ITF.
It's also worth noting the timeline. They've been refining this from 2021 to 2024. For a neurosurgery resident or a fellow like yourself, Alara, what do you think is the biggest takeaway for the next generation of skull-based surgeons?
I think it's the realization that the nasal corridor isn't a fixed box. By understanding the anatomy of the maxillary sinus and being willing to utilize these auxiliary corridors like the DALMA, we can treat much more complex lateral pathologies without the need for visible external scars or significant brain retraction.
Well said. This study from the University of Tokyo provides a very clear roadmap. EMMM preserves the drainage, the nasolacrimal duct, and the turbinate, while DALMA provides that lateral side door access. Together, they solve the problem of lateral restricted maneuverability.
If you're interested in the specifics of the surgical steps or the dual portal layout, I highly recommend checking out the figures in the paper. They have some excellent illustrations of the instrument positioning.
Absolutely. Well, that's all the time we have for today's episode on the Neurosurgery Hub podcast, a fascinating look at the future of lateral skull-based surgery.
Thanks for listening. We'll see you in the next episode.
Goodbye.